Congratulations for this beautiful scientific content meeting, and thank you for your invitation for this specific title for the presentation. I was invited to talk about this customized device for the aortic disease. Just briefly, because of a time limitation, just a single case in each thoracic and aorta, abdomen aorta case. This patient's 83 years old male present with incidental palpable abdominal mass with some risk factors, suffered these previous cancer, and the ejection fraction. Problem is ejection fraction is a little bit decreased, and the patient suffered from chronic heart failure, and recently, due to the recurrent VT, he underwent ICD implantation procedure. This patient is referred from other university hospital as a complicated abdominal aortic surgery with high surgical risk due to multi-morbidity. So surgeon refused, and the patient's family also refused the surgery due to the higher risk of morbidity. So this patient's problem is this. If you look at this lateral view, there's a celiac and SMA. There's some overlapping involvement of surrounding this major branch, and this left right kidney. The demarcation is unclear, but some view shows that this very huge size expanding with involving this right renal artery. So it's conventional technique without surgery is not easy. We have to do some snorkeling or the T-branching or any customized. Several options will be there, but I wanted to get the perfect solution for this particular case. So from the one Korean company, SNG, I talked with the president of this company. So we discussed about how to sell this by customized device. So I suggested this kind of my drawing, and we discussed. He never succeeded about this kind of procedure before, but we decided to attempt this time. So from the first drawing, according to the three-dimensional modeling by the 3D printing, so we tried to make a very accurate device according to this patient customized anatomical characteristics. And this multi-tried from second to many times, we try to make this according to the 3D model, and this on the bench test performed, and the final planning, finally we decide the hole size and the direction for the major branches, including SMA and bilateral renal. So this customized was finally made, and we discussed before the procedure one by one, and started left 16 French, left 18 or right 16 French pre-closure, and this you can see the major branch. We have to confirm angulation and the location of the SMA and celiac, and the bilateral renal distribution, and relation to the right renal involvement. However, before the procedure, we could not clearly see the fluoroscopic demarcation of this. Some haziness here, but cannot clearly see. Anyway, we started according to our plan. So right radial access. This is for the demarcating of the renal artery. So by the guidance of femoral pigtail contrast, this is a long multipurpose made by my suggestion from Korean company, 150 long MP catheter to right renal artery, and this another catheter to the this is confirmation right renal artery, and the left side also left renal selection. So this is ready for the bilateral renal demarcation, and from femoral approach, we tried to find out this is simple JR curve. We could select this ostium of the SMA, and delivered this usual 3-5 thermal wire to the be cautious of the distal branch injury. So this is a AP view and a little bit aerial view to show that this SMA and the bilateral renal demarcation. And then we confirmed the starting point of both ostial area. So backflow, and we can see the aorto-ostial junction. And then on the fluoroscopy, here's the customized device. This hole is for the SMA, bilateral hole is for the both renal arteries. Then started the opening in the first hole, first expansion of the proximal end, and this fenestrated device, along with this hole, sending the parallel wiring by the thermo wire according to the previous JR catheter. So wiring is not so difficult because wide open the hole, and the previous angio catheter was there, and slowly expanding the both renal ostial hole. Then we also easily could deliver the thermo wire and the balloon adjust for the ostial to both SMA and the renal artery. This is the SMA adjust and the renal artery selection, and the balloon adjust for the accurate opening of each pre-made hole. And this is intended for because we adjust here, but there can be distortion of the proximal end. So kissing balloon modification for the direction adjust. And next to another limb. But despite of our effort, this right opening is left renal is not so accurate. So always this can happen. Even we are accurately trying to do our best effort, but some point I could deliver the angiocatheter and the thermo wire and the balloon, further balloon modification of the little bit direction control. And this is the gross appearance of the both femoral preparation for the further procedure. So after the thoracoabdominal trunk, we started the usual standard EVAR procedure from this point by the overlapping technique of main body and the left limb and right limb. So this is a conventional EVAR technique for the abdominal aortic aneurysm. So after finishing this procedure, contralateral and the adjuvant balloon, skip, and this stenotic area, under expanded area, the reliant balloon could not pass. So conventional ballooning, then further reliant ballooning, and then this is the index procedure, final angiography. You can see due to the balloon injury, now we could see some contrast spilling into this aneurysmal portion, not perfect sealing by our initial assumption was if the tighter fixation in the proximal landing area, there may be some chance of a complete sealing. So any branch graft will be inserted, then chance of restenosis will come in the future. So best option is just to making fenestration and tighter fixation of proximal end, but unfortunately this could not get the accurate, perfect sealing. So CT angiography immediately after the procedure, we could see this contrast spilling. So next 1 week later, because we already ordered this B graft for the both renal artery stent graft for perfect sealing, so some other effort can be given like endo anchor technique or the kissing balloon further, finally side branch graft stenting. So this B graft, because I didn't have experience about this before, so this B Brown graft company, they're dealing this device, they even don't know how to do. So this was the first case in Korea before. So due to this high radial force in worldwide, this is very, very popular for the graft stenting in the side branch. So 1 week later, I did second procedure. So right to femoral, 7 French. This is checking the contrast for the baseline image. You can see continuous, contrast staining in this aneurysm portion. So we have to do something. This will not spontaneously stop. So I decided to do the branch graft. Problem is the company recommended the 7 French guiding, but usual 7 French guiding cannot deliver this big graft stent. It's bigger than at least the 7 French guiding sheets, such as the Ansel check flow or Balkin, or at that time, because I was embarrassed that this cannot be delivered, so I decided to do the sheathless implantation. So instead of the guiding sheaths, deliver the angio catheter and change it to the stiffer wire balloon modification. So this sheathless stenting was decided. So Emplacher stiff wire was delivered along with the angio catheter, and then slowly sent this big graft. This is a relatively bulky device. With the aid of this shaft support of Emplacher, I slowly could advance into the renal artery, then deployed at the minimal protrusion position. So finally, successfully could do this stenting. This is the first big graft stenting, and after deploy, pull back of balloon and the adjuvant balloon to make a more easier direction. And again, similarly, the right renal selected and the angio catheter delivered, and along with the stiff wire, easily could deliver this due to this wide angle, another big graft could insert. So big graft 10 millimeter both renal artery stenting was safely done. So this is the final image. So you can see the immediate hemostasis to the residual aneurysm was achieved. So nice sealing was achieved, fortunately. The SMA is okay, and the bilateral renal patency is okay. No leakage, no Taiwan and endoleak from this procedure. So this customized device was very successful to this particular patient, and after second procedure, no endoleak was observed. So until now, patient was fine. So we were very happy to finish this customized device. And second customized device, actually this patient underwent the dissection surgery at Bucheon Sejong Hospital before. And this patient got the recurrent aortic dissection following the distal etch, probably some etch event in the previous surgery. Hypertension, dyslipidemia, relatively younger patient. And she went to your hospital and Asan and many hospitals, but many surgeons, they refused to the second surgery due to the narrow scarring and the retrospace is limited, and there's some danger of redo surgery. So she was very disappointed. Discussed a lot for this, how to solve this problem. The surgical risk, they said, that too much higher for the safety surgery. So also decided to the customized device to seal up. Problem is the accurate tearing point. It was difficult by the CT or the angiography. So just multi-entry point evaluation was performed 3-dimensionally, and the initial drawing to the 5th attempt, the customized this direction, sometimes changing, but with the phantom model and the 3D model, many efforts were given to get the final accurate fenestration area for the innominate and the carotid artery. So this final customized device were finished, and then bench test also we have done. Branch graft was used from the SNG self-expanding stent graft because we could deliver by the pull-through technique from femoral to radial. So before we did this the board drawing, and we made a discussion how to finish this. So using this customized device, now this is a more bigger because due to thoracic device is a bigger profile, 22 French, and the bilateral renal access for the pull-through technique, and the angio guided from the left radial for this dissected area. So outside of the trunk, we evaluate the whole location, and then slowly delivered to the thoracic, similar to usual TEVAR procedure. And you can see this right radial angiocatheter is here, and the left radial. Both are guide for this location of the hole. The first hole for the innominated artery, 5-inch MP catheter was used, and checking this accurate arterial area, then matching this hole. So initial, our strategy was just to implant with the tight attachment to proximal portion, not implant the surgical stent graft, just minimizing the chance of restenosis. So anyway, this first hole sent this thermal wire, another lumen, to deliver to here, and this thermal wire should pull back to outside of radial artery. So use the snare device catching this retrograde thermal wire. We can externalize by the insert into the angiocatheter, but convenient ways to using this snare wire, quick snaring and pulling back to outside. Then both direction pull back, we can do the fine adjust of the fine location of this innominated opening, and then accurately divided this proximal area, and deploy, whole deploy, and the further deploy, and the second opening was observed, and then we could find out the exact direction along with this angiography, and then main body deploy up to distal end, and remove this pigtail catheter, and then checked. This is the index of final procedure. Still much decreased, but still some residual opacity in this dissected flap. So just the observation or the immediate procedure after 1 week or 2 weeks. So we decided to check the CT angiography. This is the first procedure, and before procedure, some thrombosis started, but still leakage. So I could not confirm whether this can be spontaneously, perfectly sealed in the future. So I wanted to do the perfect procedure. So 1 week later, the second procedure also started. I decided to implant at least one whole stent graft to innominate. So by pull-through technique, similar to index procedure, deliver the angiocatheter and the thermal wire, and externalization to outside of right radial. And this tension is very important to deliver the stiff stent graft, self-expanding SNG stent graft. So this is the optimal location I suggested, and then slowly deployed this. Geographic mix is very important. We have to do the fine-tuning to deploy this at right location, and the adjuvant ballooning, and then this is the final. Fortunately, if this is not perfect, I was considering the second branch graft, but immediately after first graft, there was no sealing, no extra passation to the previous dissected area. So this is a CT angiography, pre-procedure and index second procedure. The perfect sealing was achieved, no endoleak was observed. Serial follow-up up to 6 months, no evidence of recurrence. So this patient was very happy, and I reported this to the Korean Circulation Journal. 3D image also showed the perfect sealing after this first branch graft. So from this case, I felt some selective case, fenestration have a customized device according to patient-specific anatomical condition, is one of a very effective method compared to the customized, the commercially available device. But we need more experience, especially all the different kinds of branch graft and the technical issues, and shortening the procedure, and prevention of complication. So these are some successful cases from my experience. I'd like to share this aorta and the thoracic customized case. Thank you for your attention.